Welcome to the review of adult T-cell leukemia/lymphoma, or ATL. This distinct T-cell neoplasm is driven by the HTLV1 virus and requires navigating 4 specific clinical subtypes from viral latency to crisis. ATL is caused by HTLV1, with the primary transmission route being vertical through breastfeeding during infancy. However, we see a, quote, latency paradox, where the disease usually does not manifest until decades later, affecting only 3 to 5% of carriers. Diagnosis is often flagged by the clinical tetrad of generalized lymphadenopathy, organomegaly, skin lesions, and hypercalcemia. A critical diagnostic hallmark on the peripheral blood smear is the presence of flower cells, medium to large lymphocytes with multilobulated nuclei. Correctly applying the Shimoyama classification is the most critical management step, dividing ATL into aggressive, acute lymphoma, and indolent, chronic smoldering forms. While indolent types may present with normal LDH and calcium, aggressive types are marked by systemic symptoms and organ infiltration. For indolent disease, management ranges from watchful waiting in Japan to the use of zidovudine, AZT, and interferon internationally. The prognosis is excellent, with a near 100% 5-year survival rate in treated chronic types, provided the disease does not transform into an aggressive state. In aggressive ATL, we distinguish between leukemic presentations, which respond better to antiviral therapy, and lymphoma presentations, which require intensive chemotherapy like VCAP or CHOP. Regardless of the regimen, CNS prophylaxis is mandatory for all aggressive subtypes due to high recurrence risks. For eligible patients responding to first-line therapy, allogeneic stem cell transplant is recommended with curative intent. This therapy relies on the graft versus ATL immunological effect, though donor selection is challenging as donors must be HTLV1 negative. Newer agents include mogamulizumab, which targets CCR4 expressed on 90% of ATL cells, and immunomodulators like lenalidomide. However, providers must observe a strict 50-day washout period for mogamulizumab prior to transplant to avoid severe graft versus host disease. Without transplant, median survival for aggressive ATL is measured in months, requiring vigilant supportive care for hypercalcemia. Crucially, you must screen for strongyloides co-infection and treat with ivermectin to prevent fatal hyperinfection syndrome during chemotherapy. To summarize, suspect ATL in patients from endemic areas, classify them immediately to distinguish indolent from aggressive, and treat according to the leukemic or lymphoma phenotype. Remember to refer early for transplant and watch carefully for drug washout periods and opportunistic infections. Hope you enjoyed the session. Happy learning!